Hello, my name is Melanie Campos, and I'm going to talk about approaches to catheter ablation for persistent atrial fibrillation. Definition: percutaneous catheter ablation is an effective treatment for paroxysmal atrial fibrillation, particularly in cases that are refractory to antiarrhythmic medications. Most triggers for paroxysmal atrial fibrillations come from the pulmonary veins, so ablations involve treating circumferential lesions around the veins to electrically isolate them from the rest of the left atrium.
Atrial fibrillation is the most common rhythm disorder in the United States. It affects many people and leads to symptoms of palpitations, shortness of breath, skipped heartbeats, or even a racing heartbeat. Up until recently, the primary treatment for atrial fibrillation was the use of medications, some of which are not tolerated well, some of which have to be continued indefinitely. A new procedure called catheter ablation is a non-surgical treatment to try to fix or improve the atrial fibrillation so that patients may not need to be on medications for the control of the arrhythmia. This procedure can be performed as an outpatient, rarely requiring more than a one-day hospital stay. Patients are able to return back to normal life and activities within 1 week and are able to derive a significant improvement in their symptoms. In conclusion, atrial fibrillation is a treatable condition that now has options that are beyond the medical treatments that were available in the past.
Applications in medicine. Catheter ablation for persistent atrial fibrillation is more challenging and associated with less favorable outcomes. To improve outcomes, ablation targeted the substrates and one-time fibrillation. Substrate modification is often added to pulmonary vein isolation. The two most common techniques for substrate modification are the creation of linear lesions in the left atrium and focal ablation to eliminate atrial signals that show complex activity, sometimes called complex fractionated electrograms.
Somebody was talking about stress, and as a cardiac surgeon, I go through a lot of stress. I think I should probably monitor myself as well for atrial fibrillation. Thanks to organizers for inviting me to talk about this new procedure, which is the hybrid approach for AF ablation, surgical and catheter. Before I talk about the procedure itself, just want to touch on the basis of the background to this, which will then kind of explain why this procedure is important or necessary or should be incorporated. Atrial fibrillation has been classified as paroxysmal, persistent and long-standing persistent AF. The duration and the definition have changed a little bit over here and there. I tell my patients that in my view there are short-lasting, long-lasting and everlasting AF. That just keeps it simple for me. Cardiac surgeons are simple. The treatment for atrial fibrillation has been traditionally, initially, antiarrhythmic drugs, then percutaneous intervention in the form of catheter ablation. Surgical treatment includes more minimal access now, but also sometimes a standard surgical sternotomy. Antiarrhythmic drugs are good at maintaining sinus rhythm. About 40 to 50% patients in various studies have shown that they stay in sinus rhythm on antiarrhythmic drugs. Problem with the antiarrhythmic drug is the side effects and compliance. They also interfere with anticoagulation. The randomized controlled studies between catheter and antiarrhythmic drugs shows that the catheter ablation does have an edge over antiarrhythmic drugs. Recent trials also shown that the catheter ablation was of benefit in reducing mortality in patients with heart failure, also reducing the admission to the hospitals. And these are the guidelines from our country. And
what are the pros and cons? Data from randomized trial comparing methods of ablation for persistent atrial fibrillation are limited. Despite the paucity of data, guidelines suggest that the operator should consider more extensive ablation based on linear lesions or complex fractionated electrograms for ablation of the persistent atrial fibrillation. Whether more extensive ablation improves outcomes is unclear. Therefore, the trial compared three approaches to ablation to persistent atrial fibrillation: ablation with pulmonary vein isolation alone, pulmonary vein isolation plus ablation of the complex fractional electrograms, and pulmonary vein isolation plus liner ablation.
So here we are in the EP lab getting ready to perform ablation for atrial fibrillation. We have the patient on the table, nurse giving final instructions, going off a checklist, anesthesia, getting ready. We describe to the patient one more time what we're trying to accomplish, emphasizing our priority for safety as well as a very efficacious procedure that is very effective for the patient. So we're going to do as good a job as possible, be as careful as possible, and have a durable clinical results. Lots of electrical connections. The large patches are for the mapping system. The other electrodes are for the various monitoring systems to keep track of the patient. We start with a transesophageal echo, passing the echo probe through the mouth and throat to the level of the heart. Assess the size and shape of the heart, the valve function, and particularly look for any thrombus that might be lodged in the left atrium or left atrial appendage. And the arrow there pointing towards the left atrial appendage, Doppler signals confirming that there's adequate blood flow velocities in and out of that chamber, confirming no clots. We can proceed, nurse attending to additional technical details. We then obtain venous access, 2 sites of venous access from each of the femoral veins, guided by ultrasound access so we don't puncture any of the arteries in the groin. We perform this procedure under sterile technique, so there with gown and gloves. Each catheter is electrically connected to the console, needs its independent cord, so there's lots of setup getting all of these things organized before we start our procedure. So there we are laying out all the electrical cables, taking the ablation catheter from its sterile sheath. We'll prep that on the table, make sure the irrigation.
Issue applied in Ecuador. Patients were required for 48 experienced catheter in 12 countries. Patients were eligible. They are when 18 years of age or older than symptomatic persistent atrial fibrillation, a sustained episode less than more than 7 days, refractory to a list of 1 arrhythmic agents, and were undergoing ablation for the first time. Exclusion criteria include paroxysmal atrial fibrillation, sustained atrial fibrillation lasting more than 3 years, and left atrial diameter of 60 mm or greater.
Welcome back. Well, Dr. Link and I are now joined with cardiovascular surgeon Nikhil Polo. Jake, thank you for joining us in this conversation. I'm going to start it off with Dr. Link, because earlier in the show we talked about the treatments for AFib, that they come and go, and what options are best. What are the best options with persistent AFib?
So persistent atrial fib is a very difficult condition to treat, and there aren't a whole lot of good options. It's a much more advanced condition, and so we generally try to be more aggressive, both with medications and with surgery. And so one of the things that we're proud to be able to offer is both standard catheter procedures as well as hybrid surgical ablation.
Dr. Jake, that's where you come into play to talk to us about what is hybrid ablation.
So it's a very good question. So typically we, like Dr. Link mentioned, there's a catheter ablation and then there's surgical ablation. But usually surgical ablation requires open heart surgery in the hospital stay. So hybrid ablation is where we take the big things or the most key parts of the surgical ablation, which is ablating the parts in the back of the heart, which is very hard with the catheter, and then let Dr. Link do his part, which is easier for him. And these things have been going on in this country and in Europe for a while and have good results. So that's what we're trying to offer.
Right,
here.
and why do that hybrid ablation?
So we get the best of both worlds, where the catheter can't reach, we can reach with the
The patient is a 64-year-old male with a significant past medical history of atrial fibrillation. He was diagnosed with AFib in 2003, underwent his first AFib ablation in 2004, but shortly afterwards developed sinus node dysfunction. He had a pacemaker placed in 2006 and was started on sotalol, but yet he had more atrial fibrillation and underwent a second ablation in 2008. For 9 years he did well, but in 2017 developed more atrial fibrillation persistently and has been in AFib for the last 7 months. I saw him in clinic, we discussed treatments, and we've decided on another ablation. The electrode.
Well, in conclusion, among patients with persistent atrial fibrillation, we found no reduction in the rate of the treatment atrial fibrillation when either linear ablation or ablation of complex fractionated electrons was performed in addition to the pulmonary vein isolation. Thank you.